So Fanny and Randa, if you'd like to join. Thank you.
Hi, thank you very much, Ian, for the introduction. Good afternoon, everyone, and welcome to this session for SBRI Healthcare. I would like to start this session with giving you a little bit of a background information and overview of the SBRI Healthcare program. And then I'll pass on to my colleague Randa, and I'll give you more information about this particular competition and the theme that we're addressing through this competition. So the Small Business Research Initiative Healthcare Program is powered by NHS England and NHS Improvement. It's managed by the LGC Group and is strongly supported by the Academic Health Science Network. The aim of the program is to introduce innovation to the NHS, and it's a platform that enables the public sector to engage with suppliers of innovations. The program's got different key objectives, and the first one is to improve healthcare and really have the patient benefit at the core, but also to increase efficiency within the NHS and enable the NHS to access those innovations, especially those that are addressing particular challenges. And finally, the objective is to bring economic value to the UK. So if we could move on to next slide, please. And I've mentioned briefly about the Academic Health Science Network. The HSN was established in 2013 by NHS England, and they work as a catalyst to drive innovation, adopt them, and spread them across large populations. And they work on distinct geographies. But you'll hear a lot more about the HSN later with Piers and Guide. I'll give you more information about it. So now if we could move on to the next slide, please. Just wanted to introduce you to some of the key features of the program. And first of all, the program operates addressing themed challenges, unmet NHS challenges under themed competition scoped around those particular challenges. And it's open to any size organizations and anywhere in Europe. So it can be the private, public, or third sector that can apply to the competition. But it's particularly well suited for SMEs because 100% of the costs are covered, and it's also a quick turnaround from applications to projects being awarded. So as I said, any organizations are eligible to apply, but as long as they can demonstrate a clear route to market in their proposal, so a clear commercialization strategy is very critical. The program operates under a two-phased development approach. So applicants apply to phase one of the program through a competitive process, and those phase ones are awarded for typically feasibility projects, sort of development projects, for duration of up to 6 months and up to £100,000. And then those phase one awarded projects can then, those that are sort of awarded and complete successfully the phase one, can then apply to phase two of the program, which typically covers further development of those innovations, technologies or solutions, and sort of early evaluation. And those projects are awarded through a competitive process for durations of up to 12 months and up to £1 million. So the next slide, please. And just going into some further details about some of these costs. And as I said earlier, pretty much all the cost, 100% of the cost, including VAT, are covered, except the marketing costs as part of the applications. The program operates under EU pre-commercial procurement rules and has a tender for applicants to apply through the competition. And therefore, the applications are assessed on the fair market value. So that's the competitive part and the evaluation of the cost. The IP rests with the supplier, although there's a certain usage rights that is retained by the public sector. And the payments are made to the organisation upfront and are milestone-driven. So the projects are monitored on a risk and milestone-based approach. So that's kind of the key things to remember. So now if we move on to the next slide, I wanted to give you a little bit more information about the program and some of the metrics. So since the program was first supported by NHS England and NHS Improvement, it has continued to deliver value for money, supporting a strong portfolio of innovative technologies and innovative solutions that ultimately make it to the marketplace. The figures that are reported in this slide and next slide are those of the 2019-2020 financial year, and those figures are updated on an annual basis. The programme has invested to date in excess of £99 million, supporting businesses and products, and we've got 229 products supported by the programme. Evidence of impact is demonstrated by product making it to the market, of which 28 are selling abroad, that generates export opportunities for the UK. But also ventures in a portfolio leveraging in excess of £290 million through private investments. And finally, patient benefit is really at the core of what we do, and a big objective of the programme. And it is estimated that 4.4 million patients have benefited of product solutions supported by the SBRI healthcare programme through sales or through trials. So the next slide, please. I wanted to give you some ideas of what kind of technologies and solutions the program supported. And that sort of really ranges from medical devices, diagnostic, but also digital products and services. And some of these examples are with Open Bionics, that is a 3D printed arm, bionic arm, that's got like a multi-grip functionality. So that's a device. Or diagnostic with a company called Hsn Medical that's developed a breath biopsy diagnostic device that measures chemicals in breath to diagnose lung cancer. In terms of digital health, we've got an example with MyM Health. There's a web-based platform to allow patients with chronic obstructive pulmonary disease to manage their symptom and be in better control of their disease. And finally, an example of services with Design, that is a digital tool that is used by GPs to cross-check a combination of a risk factor, signs and symptoms in order to detect cancer earlier. So the program really covers a wide range of innovative ideas and technologies. So moving on to the next slide, and now it's time for us to give you a little bit more information about this particular competition and the theme we're addressing through this competition. And I'll hand over now to my colleague, Randa, that's going to give you a little bit more information about this particular theme. Over to you, Randa.
Thank you, Fanny. So hi, everyone. As Fanny mentioned, the SBRI healthcare program runs themed competitions to address identified needs within the NHS. And one of the themes for our competition this year is stroke and technology. The challenges in stroke care are well documented, and despite many attempts to tackle these challenges, pressures on healthcare systems, including the NHS, continue to grow. And these pressures have increased recently as a result of the COVID-19 pandemic, where high rates of severe strokes among COVID-19 patients of all ages are being reported. As such, there's a significant need to address challenges in stroke care currently, and there's strong evidence of prioritization to improve stroke care delivery in the NHS. So in light of this, we have partnered with Stroke Association to develop this competition and work together to support the development of promising solutions that aim to tackle these challenges to help deliver better treatment and care for people who have stroke. So in this competition, we're seeking innovators who are able to tackle the challenges around stroke care. And in particular, we're seeking technologies and solutions that tackle challenges associated with 3 key areas that have been identified to present significant challenges in stroke care. And these include pre-hospital diagnosis, rehabilitation, and life after stroke. So in each of these areas, we're looking for solutions that will enhance pre-hospital diagnosis and efficient access to treatment, solutions that will address the challenges and delivering evidence-based rehabilitation interventions and solutions that will provide stroke survivors with the support and monitoring that's required following hospital discharge to maximize their independence and minimize secondary consequences of disabilities. And to give you some examples of the types of solutions we're looking for, under pre-hospital diagnosis, it would be things like solutions that might enhance diagnosis in ambulance settings to maximize the filtering of stroke patients to make sure that they're being directed into the appropriate care pathways. Under rehabilitation, we'd be looking at tools that might support the monitoring of rehabilitation progress and feedback outcomes to patients. And under life after stroke, we'd be looking at provide solutions that provide stroke survivors and their families with the type of information that they need when they need it, and to create opportunities for better communications between clinicians and stroke patients. And the clinical experts here today will be speaking on the challenges in each of these areas in more detail shortly. But if you'd like to find out further information about the competition scope, you can find that within the challenge brief, which is located on our website. Next slide, please. Just to give you some key dates, we're looking to open the competition on the 13th of July. So from that date on, you'll be able to access online application forms, and the deadline for submitting the application will be the 24th of August. We'll be carrying out assessments of applications in September, and the panel will be sometime in October, with awards to be contracted in November. And I'll speak in more detail about what that assessment process looks like and what's involved later on. But that's all from me for now. Thank you.
Thanks, Randa. So we're going to move on to hear from our clinicians. And first of all, I'd like to introduce Deborah Lowe, Dr. Deborah Lowe, who is the National Clinical Director for Stroke for NHS England and Improvement, and is based at the Wirral University Teaching Hospital. Deb, over to you.
Hi, afternoon everybody. Thank you very much, Ian, for the introduction and for the scene setting. I'm really pleased to be part of the webinar this afternoon. It's vitally important for stroke medicine that we embrace what's happening at the moment in terms of it's been the most difficult of times within the NHS during the COVID period, but it's really focused providers on the importance of delivering evidence-based, innovative, technological, virtual enhanced pathways in a way that I've not seen an adoption of innovation within my 20 years in the NHS in the same way that I have over the last few 15 months. So really exciting time, and we're really optimistic that there's going to be some good progress made as part of this call. Next slide, please. So just to give you a little bit of context and background, stroke is a long-term plan priority. It, as such, has targeted funding over the next 7 years to support the delivery of the National Stroke Programme. We have a National Stroke Delivery Board that answers directly up to the Cerebrovascular Disease and Respiratory Board, chaired by Steve Powis as Medical Director of NHS England. And why stroke being prioritised? Well, it's the leading cause of disability and the 4th largest cause of death in the UK. Every year, 80,000 people are admitted to English hospitals having had a stroke, and 50% of our stroke survivors are left with disability. And this might be a hidden disability, or it might be very obvious, but the communication, cognitive, psychological, visual and fatigue disabilities are a real area that haven't had the focus that they've needed over the years, nor has rehabilitation. Stroke costs the UK economy about £26 billion a year, including 3.4 billion of these being cost to the NHS and over 5 billion being cost to social care, and then 15.8 billion being cost to informal care, so people being taken from the workplace, people having to become carers to look after their loved ones. And this is forecast to rise to 91 billion by 2035. So we do know that if we don't do something differently and we don't start managing stroke differently, we've got a significant problem in terms of managing stroke in the NHS. Half of stroke survivors as well live with 2 or more other comorbidities, so other significant health conditions. So the long-term planned stroke programme is looking at an end-to-end approach. It's looking at prevention. It's looking at how we deliver acute stroke pathways in hospitals, in our comprehensive stroke centres and acute stroke centres across the country, which there are about 115 of. It's looking at how we deliver evidence-based, game-changing interventions such as mechanical thrombectomy, where we can put a catheter in and remove a clot from someone's brain and reduce disability. And it's also really importantly putting rehabilitation and support for life after stroke right at the front of how we revolutionise delivery of stroke care. Next slide, please. So this is all being done through the format and framework of the National Stroke Service Model that was published last month. And this looks at the end-to-end approach to the stroke pathway. Next slide. And this starts with prevention. It covers pre-hospital acute rehabilitation and also life after stroke support. And that includes working really closely with our voluntary sector or rehabilitation services in the community. And there are elements and opportunities along this entire pathway for how we bring in technology, innovation and different ways of working, because we've got significant workforce challenges across our pathway that can only benefit from working just a little bit differently. Next slide, please. The delivery model for our National Stroke Service Model is something called the Integrated Stroke Delivery Network, and we've got 20 of these now across the country. And these link into our Neurosciences Centre that deliver thrombectomy, which I just mentioned. But these delivery models are really going to, or these delivery networks are really going to help us have a real focus on ownership at a regional level to deliver the national model. Next slide, please. As part of the National Stroke Service model, we've got a data research and finance work stream. And that has really prioritised over the last 18 months a few really big pieces of work that I'm really proud of. So we've been working with the NHS research team, and we were the first programme to go through the demand signalling process. And this has allowed us to create prioritisation of research questions that supports policy. And we can create and are about to create a report that will be published in the next 2 to 3 months to call out to our funders, NIHR, researchers and academics with key research questions across the pathway. And you can see on the flow diagram just on the slide the process that we went through. Next slide. So these workshops have taken place over quite an extended period, really, because we were hampered slightly with COVID. So our first workshop was completed in July 2019 with a subsequent workshop in February 2021. And that was attended by patient and public voice, policymakers, researchers, academics, and people, clinicians working within the field of stroke to outline our key priorities. Next slide. That's dovetailed into another piece of work that we commissioned from King's College London, led by Professor Charles Wolfe, which looked at the evidence that we currently have across the end-to-end stroke pathway and informed where the current evidence gaps are that we really need to prioritise. And you can see there are 7 areas, I won't read these out, listed on the slide. This is in the public arena, it's been published by Futures NHS. And we've dovetailed this with our demand signalling work, and this will all be produced within the upcoming publication. Next slide, please. We've also worked very closely with the Stroke Association, who've done a priority setting partnership that's due to be published on the 24th of June. The James Lind Alliance process has been used, which is obviously a robust process, bringing together our public and patient voice, so people have been affected by stroke, their carers and professionals, to set a research agenda. The clear principles and stages have been followed, which is a very transparent process, as you're probably aware of, and has given us an ability to look at the evidence base and make sure that we've got a really clear equality of voice. The stages followed are on the flow diagram, and these have really identified, and what's been nice to see is it's identified priority areas for research very similar to the demand signalling work, so we've worked in tandem. But the priority areas in research across the stroke pathway in all nations of the UK have been established, and these are prevention, diagnosis, pre-hospital and hospital care, and rehabilitation and life after stroke care. But the real key areas that have come from the James Lind Alliance priority setting work are around prevention of stroke and the evidence for psychological impacts of stroke and how we actually address them. So as I said, these will be published on the stroke.org.uk/PSP website on the 24th of June. Thank you, Ian. I'm going to leave it there and hand over to Chris.
Yeah, great. Thank you very much, Deb. Chris, Chris Price is going to come and talk to us. Chris has got quite a strong background in working with companies and technology particularly around the acute end of stroke, but also is interested in further down parts of the pathway as well. So Chris is going to come and talk to us about some of his experience and some of the challenges in this area. Chris.
Yep, thank you very much, Ian. Good afternoon, everybody. It's great that SBRI are providing us with this opportunity. Shall we move on to my slide? Thank you very much. I've just got a few slides here to outline the key pre-hospital challenges and some of the opportunities that might be available for new technology. Thank you. So a lot of the purpose of pre-hospital care is to try and get patients very quickly to the right place for emergency treatment, because stroke is a treatable medical emergency. It's a huge population of 85,000 NHS stroke ambulance admissions per year. As Deb's already outlined, it creates a very significant health and economic burden. But we do know that very rapid assessment and rapid emergency treatments in specialist care settings do optimize outcomes that improve patient lives and reduce costs. But there are a lot of challenges in here. The pre-hospital assessment leads through to a hospital assessment that's quite a complex pathway. And this is also challenged by the fact that pre-hospital suspected stroke is a very mixed population, where this complex sequence of events needs to happen very rapidly, and we're talking in the matter of hours to get people to the right place for these treatments to work effectively. And only some hospitals provide some aspects of specialist stroke care. And only some of these hospitals can provide all emergency treatments available for patients that make a difference to their outcomes. And although there are quite a few opportunities potentially for technology to assist in pre-hospital and the interface with hospital stroke care, a lot of them revolve around more accurate triage and faster treatment. Next slide, please. So one of the challenges is that many conditions initially look like stroke, particularly from the ambulance assessment viewpoint. Because of the public awareness campaign, people, I'm sure, will be all aware of the face, arm, speech test, although the T has now become time to emphasize the importance of quickly recognizing symptoms and calling 999. But the FAST, is 20 years old now and is still the only thing that we have that's commonly used in the pre-hospital setting to identify patients with stroke symptoms. Now, it does identify about 70% of patients with stroke, but its specificity is poor. So out of 100 patients who are suspected of stroke by the FAST symptoms, only 60 will have stroke and 40 will have another condition that looks very similar, but actually needs entirely different treatment. And this really hampers the efficiency of the pre-hospital stroke pathway. And although lots of alternatives have been tried in terms of different symptom combinations, every time you try a different combination of symptoms, you reduce the specificity, really. So anything that improves upon this recognition of stroke issue will definitely increase the efficiency of stroke care and make it more likely that patients will get to the right place more quickly for treatment. Next slide, please. And this is because the suspected stroke population in the ambulance actually is a very mixed population. If you start at the top of this tree and think about all the patients who are FAST positive, who have stroke symptoms beginning very recently, in fact, many of them have not stroke conditions, as I was just saying, they have what's often termed a mimic condition. Some of these patients will get better very quickly and in fact have a transient ischemic attack, or TIA. That leaves the confirmed stroke population. But even then, these need to then be broken down into groups that have very different emergency treatment needs. They'll either be ischemic stroke, which is 85% of the stroke population, or hemorrhagic stroke, which is 15%. And the treatment of these two groups is very different. Amongst the ischemic stroke population, you've then got people whose stroke is due to a blocked small vessel or a blocked large vessel. And the small vessel patients need a different treatment considerations to the large vessel. And the large vessel population, although are not as common, are the ones who maybe have got the most to gain from emergency recognition and transferring to places that can give them effective treatment, because that is the group who will have the most severe disability as a result of their stroke. Next slide, please. And to add to the difficulty, all the time, people during a stroke are losing brain cells at a phenomenal rate, and it has been calculated in the past that that's nearly 2 million brain cells each minute that stroke is not treated. And we have effective technologies for treating particularly ischemic stroke, intravenous thrombolysis, drug treatment, often referred to as clot busting, in an injection within the first 4.5 hours of any ischemic stroke that meets the criteria, will lead to a good chance of improvement in symptoms. And that's about 15% of stroke patients overall that's suitable. Whereas for patients who have the large vessel blockage, those patients may be suitable for thrombectomy, where an intraarterial catheter actually pulls the clot out, as well as them receiving thrombolysis usually. And that's maybe about 10% of stroke patients. But these treatments are not available in all hospitals, but we only have limited time to give them. And the sooner they're given, then the more effective they are. Next slide, please. And in the UK, one of the challenges is the distribution of our stroke care. The map on the left shows circles and stars. The circles are the acute stroke units, the sort of nearest place that people might go to if they're suspected stroke by the ambulance service. And these can all offer thrombolysis treatment. But the stars are much fewer in number, and those are what's termed comprehensive centres, which is where the only places are that can offer this thrombectomy treatment. And what has to happen is that many patients suitable for thrombectomy would have to move from the circle to the nearest star if they are suitable for thrombectomy. And that leads to a delay in treatment of about 90 minutes minimum. And it's certainly a factor which is holding back the maturation of the thrombectomy services in the UK, which is represented by the map on the right. And really the more rural areas are, the slower the expansion is of the activity in these thrombectomy services. So anything that can recognize these different types of stroke, and particularly recognize patients who have got blockage of one of these large arteries and might need to go to a thrombectomy center very quickly, rather than to the nearest stroke unit, that would be of great value for faster delivery of these treatments and better outcomes for patients and better economic and efficient use of resources. Next slide, please. There are a couple of things that are worth thinking about in the pre-hospital environment specifically. We have to bear in mind that the introduction of any technology into use in ambulances has some special considerations. Ambulance services, of course, operate continuously with an unpredictable demand. As such, only a proportion of that work is stroke, and the ambulance service itself obviously doesn't know when there'll be the biggest demand for stroke as a particular patient group. In fact, stroke only is 3% of the ambulance workload across large geographical areas. This results in the way that ambulance services operate. They have dispersed units, obviously the ambulances, and a dispersed workforce. And this produces some challenges, particularly for training and restocking and data communication and retrieval of information, which produces challenges in research as well as clinical practice. The storage and power supply is limited on vehicles. And things have to be as portable and robust as possible in their design. And ambulances also suffer extremes of temperature, which might not occur in hospital settings. And these are important things to bear in mind when thinking about introduction of technology in the pre-hospital setting. Next slide. And finally, I think it's worth just emphasizing how important it is to have added value from the introduction of technology in any setting, really. The FAST test has stood this test of time, really, because it is easy for the ambulance staff to use very quickly, and it's easy to train the staff. So anything that is on top of that has to be worth the extra time that it takes and worth the limited resources that it might cost. That any technology should integrate into care pathways without creating delays. And there should be consideration about how the data it generates integrates into existing data systems for clinical governance purposes. There may be wider impacts on response times and resources for the ambulance service from using new technology. And it's important that any technology that's introduced has involved various stakeholders, so clinicians and services, and the public as well, so that we can understand the appropriate criteria for when it would be deployed. It may not be appropriate to be used in every patient. There may be trade-offs to be done in terms of its effectiveness for sensitivity and specificity, depending upon the complexity of the technology and its cost of use. The clinicians have to be happy with the user interfaces and the physical design, and the training shouldn't be too intense. There may be logistics around the supply and obstacles to scaling up. And for people who are applying to the competition, I wish you luck, but please try and bear these factors in mind when you put your application together. Thank you very much.
That's great. Thank you very much indeed, Chris. That's really helpful. So we're going to move on to Rebecca Fisher, who is a Stroke Association Senior Lecturer at the University of Nottingham. And Rebecca's going to talk to us about the other end of the pathway, so rehabilitation and life after stroke. Over to you, Rebecca.
Thank you, Ian. Thank you for the invite, and good afternoon, everybody. Next slide, please. And the next slide, please. So this is just what I'm going to cover in the next 10 minutes. I want to highlight the multifaceted nature of stroke. I'll then talk about both rehabilitation and life after stroke. Like Chris and Deb, I will mention briefly about the stroke care pathway and then suggest some possible targets for technological solutions. I've also added this picture here too, as it was one that was often used by a stroke colleague of mine, Ozzie Newell, who has now sadly passed away. Ozzie used to use this to emphasise that a lot of attention had been placed on hospital-based care, quite importantly and understandably, but this was only a small part of a stroke survivor's experience of recovery. And I'm very pleased to say, certainly under Deb's leadership, that nationally, stroke rehabilitation is very much the focus, as is supporting recovery over the longer term. Next slide, please. So Chris has mentioned the FAST campaign before. I've added it here to point out the fact that there are many different consequences of stroke. And whilst these particular ones may be easier to spot, many are hidden. Also to make the point that time is important, not just to get people into hospital, but with regards to provision of rehabilitation. It's important patients receive rehabilitation in hospital, but also important that they're provided with rehabilitation over time at the right intensity to support their recovery. Next slide, please. So sorry if that's a bit blurry, hopefully you can see it. This slide I've used to highlight the different aspects of stroke. Deb touched upon it. And the focus of rehabilitation, therapy and associated interventions. So stroke affects body function in many different ways, with possible associated impairments listed there. Note that personality, energy, memory and attention, potentially hidden at first, can also be affected, as well as mobility and movement. There are rehabilitation interventions designed to address these impairments. However, it's also important to consider how these impairments affect activities of daily living, and hence how interventions could be used to promote recovery by enabling stroke survivors to participate in these activities. Lastly, in thinking about life after stroke, we also need to consider how to support stroke survivors with what's in this diagram termed participation. So importantly, recreation, leisure and social activities. Next slide, please. So it's also worth considering the stroke care pathway and where technology might support delivery of rehabilitation. This is a diagram that Ozzy drew for us at Nottingham to help us explain to people what the different elements of a stroke care pathway were. So it's composed of multidisciplinary teams, and it spans across hospital and community services, and it includes delivery of care and rehabilitation for stroke survivors in their own home or place of residence. It requires partnership working between health, social care and the voluntary sector. And again, it's important to note that stroke recovery can happen over a long period of time. Next slide, please. So here I'm offering some thoughts on possible targets. It's not an exhaustive list for technological solutions to support stroke survivors with regards to rehabilitation and life after stroke. There's been established interest for some years in robotics, so focused on upper or lower limb rehabilitation. So the attraction here is the need to support high dose repetitive therapy and practice to promote recovery. Given the recent pandemic, there has also been a lot of interest in tele-rehabilitation and remote rehabilitation, and scope for designing rehabilitation platforms and interfaces and use of apps is great. I think that an interesting aspect to consider, and Randa mentioned this, is the importance of feedback to provide the stroke survivor with information about their progress and performance. Some considerations from my perspective, I think where stroke survivors are expected to access or use this technology is important to consider, because at home alone is very different from being supervised in a hospital ward or clinic. There is also concern that not everybody can access the equipment or IT that might be necessary. So this should be not assumed, but definitely considered. And lastly, there's an emphasis of this on motor behaviour, so muscles and movement. I think you need to consider other potential consequences of stroke, such as motivation and emotions, and how these influence this. Next slide, please. Another area to consider is the use of technology in the stroke care pathway, given that evidence-based stroke care relies on collaborative working between multidisciplinary teams. So there's great potential to support decision-making and communication between staff to support smooth transitions across the care pathway. Also, technology could offer better ways to provide information to stroke survivors and their family about the stroke, and also the care that they can receive, which research suggests could be optimised. There's also opportunities for peer-to-peer support facilitation and support between stroke survivors. Stroke guidelines also recommend systematic follow-up reviews for stroke survivors, what are termed 6-month reviews, to identify and review needs and goals. There may be technological approaches that could assist with optimising the impact of these, and also with regards to more frequent monitoring between follow-ups or between therapy sessions. Lastly, there's a lot of interest in self-management and potentially some technological applications that could support that too. Next slide and last slide. So to summarise, it's not an exhaustive list, but some examples for use of technology in rehabilitation and life after stroke would be to augment therapy with repetitive practice, for communication and data sharing across the care pathway, and for monitoring and self-management and follow-up. Just some last words from me with regards to what I would consider additional important considerations. I think the multifaceted nature of stroke is important as is the need to consider the range of disabilities and, importantly, goals of stroke survivors. I haven't had time to say too much about this, but the impact of stroke on family members is also very much worth bearing in mind. I'd advocate keeping it simple, easy thing to say, but where possible, because I think there may be a temptation to get lost in the technology. Need to keep what matters to the stroke survivor at the focus. And lastly, I think involving a range of key stakeholders in a project would be key, particularly those with experience and knowledge of stroke and the stroke care pathway. Thank you for your attention.
That's great. Thank you very much, Rebecca. So we were hoping to have a patient, a stroke survivor, to be able to speak to us today, but he's unfortunately not been able to join us at this stage. So we're going to go into the Q&A. So oh, hang on, he is here apparently, but I suspect he's in the audience and not got the link to actually be able to present. So we are. Lee, you are here. So
perfect. Hi there.
In which case, we'll postpone the questions for the moment, and we'll move over to Lee. So can we have the slide back, Alice, please? And so Lee is a stroke survivor. Is going to talk to us a little bit about the patient from the patient perspective. So Lee, can I hand over to you, please?
Yes, thank you very much. And I don't think I can start my video, but I'll keep talking anyway. So a couple of lines on me on the screen. And as you can see, this all happened in March 14. It was very much out of the blue. I was doing a lot of travel at the time internationally for work. I'd got off a flight from Hong Kong on the Friday. This all happened Saturday morning early, just as I got into the shower and put the shampoo on. And actually, my first thought was, I'm going to be going to A&E covered in shampoo. That's not a good look. I need to do something about that straight away. And so this was as I can see from my notes in front of me from UCL, this was a left MCR territory infarct, cryptogenic. It was slightly odd to the point made it just now about everything being, every example of stroke being different. In my case, I presented to the Whittington Hospital first because that's the closest A&E in London to me. And, you know, when you turn up to these places with some symptoms that come and go, you're in an A&E environment, and that can take time to get through, which obviously happened on the Saturday morning. And they struggled with symptoms. They struggled to identify really what this was about. I think fast wouldn't have helped either them or me. I mean, my sense was that something was wrong because of the sudden heaviness of right arm. And I think the key thing for me was and this is probably not something that people experience that much, but there was a distinct high-pitched tone that I could hear on my left side. So that was quite odd. I knew that those two things together were not healthy, that something was going on. I also knew, it wasn't a heart attack or anything, so I was perfectly able to walk and function, but it did feel heavy on the right side. And so we ended up walking around the bedroom with my daughter in front, and I was holding on to it just to see how my leg was working. It did feel a bit odd. So I thought, right, let's go to A&E. And I think that's the important point, that it's not actually until, and this was about 8 a.m. in the morning, 8:30, and their conclusion was blue light me across to UCL, and playing absolutely safe. And when I turn up at UCL again, the symptoms were not apparent, and it's not really until about 11:25 in the morning, having readmitted to UCL, that they sort of start to look at me and decide that there had been some sort of incident. And then, of course, I go through MRI. But it's actually that evening, whilst in UCL, that the bigger damage was caused. So what had been a sort of indicator, 8 to a sort of 11 o'clock on the Saturday morning, didn't result in the sort of much more invasive consequences. And then it's waking up on the Sunday morning with the specialists coming to see me, with my family turning up to see how I was, that it was obvious that something more had taken place. And I think, to be fair to UCL, they also were taken unawares, and they they've changed their process since, where when patients admit, they do keep a watching brief much more during the day when you're admitted to make sure that there isn't further episodes. And I think in hindsight, they probably would have put me on clopidogrel or, clot busters, even aspirin, much more quickly, because clearly there was a clot that had formed that was sort of floating around, left side, and then sort of did its damage that during the night. Now, my recovery has been excellent. In fact, although I had 3 months of recovery, and it did take time for the brain to rewire, as we know it does. But let's just say by December, I was off skiing with the family, and not finding too much in terms of problems longer term. It has been a case of initially I couldn't run again, for example, so I started to walk on treadmills and then build that up. I think the rehab services supplied by the local authority were absolutely key in those first few weeks, because you want to get yourself better, but you're not going to get better quickly without a bit of effort. And then you need somebody to say, right, we're going for a walk around the neighborhood to see how that works. Let's see how you go up and down stairs. And so, although like lots of stroke victims discharge quickly from UCL within 2 days and you're back home, I think that sort of constant support, that regular twice weekly, as it was, visits by people who know what they're looking for, it is really supportive, really helpful. I think that the addition of tech into this picture for those that are immediately suffering consequences, and they're all different, as we know, depending on which particular cells have been zapped, that could make a fundamental difference. Both connectivity, in other words, keeping those that have been impacted by a stroke connected with advisors, so that, because the condition changes quite quickly. For example, when I was in UCL the first day after that Sunday, so the Monday, I needed help to walk to the toilet. Nurse each side, that sort of help was the kind of support I needed just to move. But during the Monday, for example, when in the hospital bed, my right ankle started to move just on its own, just sort of reconnecting. So, finding the pathways through. And that meant that when I went to the toilet next, I could do it without any help. It was like a revelation to how quickly, the plasticized experience can really impact. And of course, before that, I was perfectly healthy. I'd actually had a medical through my employer, Aviva, who I work for, 2 weeks before. The only outlier in that, other than everything was super, was slightly raised cholesterol at 6.2. And, I was obviously thinking about how I might manage that. I would say that, who knows what the cause was. They did further investigation at Queen Square afterwards, but just the usual tests. We couldn't find a cause. Everything else was absolutely as it should be. And I'm in that sort of 35% of, never really find a reason. It could be connected to the long haul flights, of which I was doing a fair bit, but who knows? And, the blood suddenly just decided to get sticky and clot. So I think I am in a space where, super grateful I've recovered. I can sort of resume life, back to work by the September following the March 2014 episode. Really understanding employer massively helps. And I think, I've had other people at work actually, or relatives have a stroke, and then you can talk to people about recovery points and what to push for and when it might make a difference. So that, I think that is an important point here, that because everyone's different, you need different levels of care and different assistance, and finding the points of encouragement in points of improvement can be quite elusive for some. And I think it's quite easy to give up if you're, perhaps if I was 20 years older, it would seem much more of a struggle. And in fact, obviously, when I was at UCL, I did see others who were much more elderly in much more difficult situations. So that probably uses up my time, I think, does it? And if you want to ask some questions, I'm very happy to answer any.
That's great, Lee. Thank you very much indeed for that. So really useful to hear some real experience of that. And if people would like to ask Lee any particular questions, please do put them up on the Q&A. And we will come back to you, Lee, to ask if any of those turn up. Can I ask the clinicians and I guess Fanny and Randa to come back on screen as well, because I think what we want to do is to pick up on some clinical questions and also things around the brief. If you've got questions about the actual process or the program itself particularly, and the details of actually how to apply and those kind of things, can you save those up? We're not going to deal with those at the moment, but we save them. You can put them. You can start posting them if you want to, but you'll get a bit more information in the next session and we'll pick those up with the Q&A at the end. So I wanted to pick up one question which for some reason our system decided had been answered live and it hadn't even been asked yet. So Simon Bilton asked a question about are there standard sort of symptom checkers which could be used, in inverted commas. I'm guessing, I don't know, maybe this is one for you to start with, Chris. Sorry, I think you're on mute somehow.
Is that any better?
That's
there we
better.
Go. Sorry about that. So it depends on the context of that question, I think. As I said, there are actually quite a number of different stroke recognition scores or scales that have been tried, and they've all got pros and cons. They always end up in this situation where you are trading off the number of patients with stroke you recognize versus the number that don't have stroke. And FAST actually overall seems to be internationally accepted as possibly the best compromise. But in terms of standard, I suppose the role of technology in this might be something that helps standardize the severity maybe of symptoms, or as sort of something that is taking information that a clinician has extracted during their patient assessment and is combining that in a more complicated way than just the FAST. So I think there is potentially a role for technology in that sort of clinical assessment process, as long as it's quick and isn't actually asking the clinician on the scene with the patient to do something which is incredibly complicated and would require training and room for error.
Great. Deb, I think you raised your hand there to say something.
I was just going to add to Chris's comments around the role for technology. So there's been some really exciting pilot work done over the last 12 months in north central London and the southeast, using tele-triage in the back of an ambulance for suspected stroke patients. And that first set of data is just starting to come through, and it's looking really, really very positive. Obviously, East of England have been doing something similar for a period of time, but this is just really basic, simple technology with a camera in the back of an ambulance or a wearable device, and a triage to a stroke specialist directly. And some of the follow-up data looking at that is suggesting that actually it's a really, really effective way of screening. I think it's having that emergency clinical expertise available to our paramedic and ambulance first responders. Thanks.
So that raises a question. It's not one of the ones on the list, at least I don't think so. I haven't got that far down, but it just struck me as a thought that how can people who potentially thinking about applying and have some ideas find out what is actually going on in terms of that sort of trial that where they're testing that? How would any of the potential applicants to this competition know that that's already happening? Maybe that isn't the best option to go for. Maybe they've got an idea of that in some other area. Or is that information sort of publicly available, or at what level?
Don't know if Chris wants to come in. I mean, there'll be certainly what I've just alluded to. I'll answer to you specifically. This will all be published during the course of the year we would expect, but also via the Futures NHS platform, we do try and update all of the regional networks in any of the pilot work that's happening.
So Guy, you've leapt in.
Yeah, I think Piers isn't here yet. He's talking about the AHSNs, and part of their role is to try and connect people. That's always the difficult bit. I'm not saying it's easy, it's all going to be magic and you're going to be connected to some great researcher and some great company, it's all going to work. It's hard work along the way, but contact your local AHSN. They can put you into innovation pipelines, they can potentially connect you to companies that have an interest, and some early work can be done for people to develop their own company and become sort of put for an accelerated process. So there are means and ways, but no, it ain't easy like life.
Thanks, Guy. Question at the top of the pile is, what thoughts do the clinicians have on the use of biomarker data, for example, clopidogrel metabolism status, knowing that perhaps 1 in 4 patients can't metabolize, to help delivering precision medicine to stroke patients as a part of a transformed pathway, for example, getting patients onto the right treatment at the right time? So use of biomarkers, I guess, point of care testing, that kind of thing.
Yeah, well, I'll pick this one up. So the obviously biomarkers potentially have definitely got a role to play in pre-hospital stratification of patients into different groups for the mechanism of their stroke, possibly even in some way in terms of measuring the potential for them to gain benefit from one of the emergency treatments. And I think that is the main focus of biomarkers in that area. I think there may be some semantics here in terms of diagnostics versus precision medicine. I think it all depends on the context of how the technology is being applied. There might be some very novel uses in terms of biomarkers being used to determine that, for instance, that people have maybe got a very low risk TIA, for instance, that could go down an alternative pathway and not need emergency hospitalization. So there are other uses as well. It's not just about ruling in stroke, it is sometimes about stratifying the risk and ruling out other issues. But I think it's always have to bear in mind that whatever technology is being developed, it should be possible to integrate it into a clinical care pathway, as sometimes great technology comes along, but actually it's expecting too much of the existing care pathways to shape around the technology rather than the other way around.
So that's an interesting question then. Really innovative, some really innovative technologies may actually be disruptive to the pathway. And so I guess that's the question is, how much of that is allowable, how much of that is wanted, if it's going to make some sort of significant difference. Maybe that's a question for Deb particularly, I don't know.
I mean, so thrombectomy was an innovative technology that completely shook up the way we are expected to deliver hyperacute stroke care. But that was gratefully received because the evidence base was so profound and strong. So technologies with a great evidence base that we know will save life and disability, and also ultimately, affect efficient delivery of a care pathway is always welcomed. But there may be some technologies that actually their integration right now from a workforce perspective or the actual impact on the stroke pathway isn't great enough. So not everything will fly, obviously, but I think everyone knows that.
So another question, a colleague I'm working with has a great idea, which has been worked up with a local hospital. No company partner. Could you advise on the best approach to this? We're in discussion about stakeholder engagement, but support would be appreciated. Thanks. That's anonymous, so not quite sure who it's going to be. But I guess that's a sort of common issue for many people who are looking for solutions, who have ideas and don't quite know where to go.
It sounds like Guy answered that a little bit earlier.
I think he did. That's
go to your local academic. Yeah, thanks. Not correct.
Yeah, maybe contact your local university, contact your local academic health science network, and go from there, really.
Great. There's This is a very long question, so hopefully you won't forget the beginning before we get to the end of it. So it says this: we've been working on transforming the stroke pathway for stroke patients post-discharge. The pathway makes use of patient-generated physiology data and PRO's data, which is exchanged securely with data in the EHR, coupled with two-way messaging between patient and clinician to provide a prioritized remote view of the patient to support with community management. We've been doing this with an NHS board in Scotland and have thoughts about how AI and machine learning can be introduced to further improve the service. Do we need to have a relationship with an AHSN or an entity in England to participate in this SBRI? So maybe that's one for you, Fanny. So you're on mute, Fanny. That's it.
Sorry, I'm just trying to sort of get back to it. So that was in relation to...
It's about they've been working with a hospital in Scotland and some companies in Scotland. Are they eligible? Yeah, do they need to work with an AHSN, etc.?
Yeah, so we strongly recommend working with the HSN, and that's going to be covered a little bit later by Guy and Piers, most definitely. And I think there's some questions around whether people can apply from everywhere in the UK or just England, but the competition is open for anywhere in Europe and also Scotland. So in terms of site, that's not a problem at all from Scotland.
Great, thank you. How many people are involved in a stroke survivor's recovery after their primary rehabilitation? What tools do they currently use, and how do they coordinate their care? Well, that's a big question. I'm gonna throw this one to Rebecca to start with, because it's kind of that late stage post, I guess. And I guess it's, yeah, it'll probably come to all of you eventually. But Rebecca, I don't know if you want to start some idea around this.
Yeah, it'd be interesting to know if the person who is on the call to expand a little bit. I mean, you know, teams are quite a large size. There's numerous different types of therapists, doctor, nurse. So, you know, when I say multidisciplinary team, there's quite a large group of people who meet regularly to discuss particular stroke survivors and the treatment that's provided. And then, you know, certainly in the community, there's home-based visits by members of the team on a regular basis. I suppose if it's connected to my point about communication, there is then a multidisciplinary team based in the hospital. There's also teams associated with the voluntary sector. So there are quite a number of people that need to be coordinated and that need to communicate in order to provide the best care available to the patient, because of that multifaceted nature and because of the fact that therapists and doctors and nurses need to work together. I don't know whether I haven't said a number, but.
Anyone else want to leap in at that point and suggest a number? Or
I don't think you can. The whole point is every stroke patient, stroke survivor is an individual. Many stroke survivors are discharged from hospital having made a full and complete recovery, just having medical follow-up at 6 weeks or 6 months, hopefully. Others will be discharged with daily input from physio, occupational therapy, speech and language therapy, psychologists, voluntary sector, etc., including support from health and social care with enablement and carers. So it's a really diverse picture. But I think, going back to Rebecca's point, what we found certainly over the last 15 months during COVID is the use of virtual platforms to allow connectivity between hospital teams and community teams has been really pivotal. And community teams are getting used to that a little bit more now, and they need the right technology and the right integration to allow that, and the right sharing of information, which we still not nailed really, to make sure that everyone knows the stroke survivor's journey.
And I guess just to add, sorry, the point about what's being used, Chris can talk about robotics. They've done a large piece of work in terms of investigating robotics in Newcastle. But more recently, and a more simpler level, certainly with regards to supporting patients in their own home, there's been lots of adoption of quite simple remote contact, as Deb was talking about, which I think has got promise. So it doesn't need necessarily be a sort of fancy bit of kit. It can be just that regular contact, face-to-face contact over remote communication.
Oh, that's great. Thank you. Leah, we've got a couple of questions for you. Apparently, Alice says you are able to turn on your camera now. So,
okay, I've done that. Hello.
Great. So first question was from Claire, says, can I ask Lee how exercise has helped him on recovering?
Yeah, massively important. I would say that although quite low key to start with, it's been a constant, essentially from the end of March, early sort of April 2014. I've been discharged probably a week, and I was focusing very much on just obviously just trying to walk and recover that skill. And yet by sort of May, June, the access to a treadmill, because it can support on both sides, because somebody can supervise, and because it can teach the brain how the muscles all work together, even though you don't know that's what's happening, was hugely helpful. Swimming actually also, I think, for stroke victims, although there's obviously a safety issue there, and again, supervision, for me was massively helpful and supportive, and it uses muscles in a way that you can't replicate in doing other things, doing weightlifting or weight enduring exercise. And there's also that sense that if you can do things outside, and it was kind of spring and it was better weather, that also helps. It's easier to be out and about and exposed to noise and sound and senses, so that the senses are all working. I would say the one thing for me that exercise has really done is help on balance. It's something I really focus on in Pilates, because part of my sort of ongoing care is regular Pilates sessions each week, and I sort of do that before I start my day a couple of times a week. And balance, the sixth sense, often ignored. You don't realize how it's been impacted until you try and do things that take you by surprise, and probably for some stroke victims might mean a fall. So I think for me, the idea of that balance check and developing balance has been massively important, because it's helped in walking, it's helped in running. All the other bits, I think, follow from that one thing. And you realize where the deficiency on balance is still, because there is a slight deficiency on balance on my right side, but you can work on it and definitely improve it. And who knew? So, you just think it's sort of hard results from exercise, but it manifests in other areas.
That's great. There was a sort of follow-up question, I guess, which is if you, from Sue, which says, what would have most helped you in your home recovery that wasn't available? If there was a bit of technology or a bit of something that might have helped you, that we didn't have, what would it have been?
Yeah, that's the £1 million question, isn't it? Probably, and maybe that there's an issue here for patients over obsessing on improvement too quickly, which can drive stress and challenge. But probably something that would have suggested, for my particular case, fitness or recovery that would be most beneficial. So in other words, try and map specific challenges that patients are going through to possible ways to reduce impact or improve well-being. And because as Deborah said, everyone's different, every patient's different, and they start from a different place before the stroke and they're in a different place after the stroke. Maybe it's that matching of, this would be particularly good in your case, given your medical outputs. This would help specifically on this deficiency. And of course, things that people wouldn't necessarily think might help, like art, for example, or exposure to white noise, or anything else that might stimulate brain pathways, are not easy to find, because there's just so much information for stroke victims. And the problem they have, particularly when things happen, is they have much reduced ability to absorb information and process information, because the brain is recovering, and that takes, as we know, a huge amount of energy and effort, even though it's not obvious externally. So something that could hone and design a recovery plan for individual patients that could be tech-based might be the way forward.
That's great, thank you. So another question for, I guess one of the clinicians here. In terms of rehabilitation and life after stroke, would a technology that is applied during hospital acute treatment, but then assists in improving brain plasticity and improves overall stroke outcome, would that be considered something that's eligible? Is that something that we're looking for?
I mean, I would have thought that yes, essentially within the scope of the challenge today. Chris, I don't know if you want to come in.
Sorry, we've lost you for some reason.
Yeah.
That's it. Got you now.
How about that?
That's better.
Yeah, for some strange reason, my mute button has inverted its function. Maybe it's an issue for technology. So rehabilitation doesn't begin some weeks later after the acute phase. It really begins right at the very admission to hospital. And so I don't think there should be a time limited sort of definition of when rehabilitation and life after stroke technology should begin. Maybe not in the ambulance, but you know, I think once people are clearly diagnosed as stroke, that they can benefit from technology to help them restore function and get back to their lives. Yeah.
Rebecca, anything to say particularly around that, or?
Just the improves brain plasticity. The researcher in me would want that to be supported, but that's just the researcher in me coming out anyway.
Well, here's another question about research. So Tom is interested in hearing thoughts on the challenges in developing robust clinical research methods for looking at robotic solutions in sort of mobility rehab. So, you know, what are the challenges there, and what are there some appropriate methodologies? Are there things they should consider, or things that they should definitely not consider? Yep.
I know Chris is going to, but what I would say is I think as part of all of this, I've been sort of thinking about the place for research. And I think, you know, the earlier question around you don't want to stop innovation by worrying about all of that, but you don't want to put money into an innovation when research absolutely has shown time and time again that it doesn't work. But I think for me, it's important that there's the room to develop something, but then of course, later down the line, research needs to happen.
Yeah. So I think just to agree with Rebecca, I think the key thing in the competition is people linking up with relevant clinical expertise, because, for instance, with that example about when to apply rehabilitation technology, obviously patients have to be medically stable, and in fact there is some clinical evidence from trials that actually getting people up too quickly might be a bad thing, but it does depend on the type of characteristics of the different patients. So people need to link up, and it is one of the challenges in stroke that there is so much variation. So people need to be clear who they're aiming that technology at. In terms of this, the question about sort of portable assisted moving or robotics, and there is some debate about what that is and what it isn't, then I think there is quite a lot of research already about situations where that is or isn't helpful. And again, people I think have to be very clear about what it's seeking to do as to whether it will be viewed as useful, supplementary. Is it something the patient is doing with assistance from their carers, or is it something that is assisting the therapists, and it being seen as an add-on and not necessarily substituting good quality multidisciplinary rehabilitation?
And Chris, one point I'd mention is that the potential is there that the robotics might interfere with slow down plasticity recovery, because in my case it kind of took 6-7 months to really regain the full use, full strength. And if you intervened at a certain point and the brain decided it needs to try as hard, you might not see quite the muscle recovery or the connectivity of you know, tendon recovery, for example. So that would definitely be a concern, that tech would initially help carers, but it might not help the patient longer term.
Yeah,
Rather than
absolutely.
you're dead right. It's not scientific, is it? But saying that time is a healer, but it is often, and we do see that time and time again. And the recovery journey post-stroke is often years and years in the future, isn't it? Irrespective of intervention sometimes.
So Rebecca, I made a note of something you said when you were talking, which I wondered if you wanted to just elaborate slightly on, because we're kind of mentioned this partly about particularly this long time factor. It is, you mentioned something about the impact on family and carers, and I'm just wondering if how this particular challenge in terms of looking for technology that might help. We're always focused on the patient. How is there technology that might help, or in what way can the family and the carers be involved in, or could be and helped to be involved in that through technology?
I think it's just acknowledging the fact that they're individuals too. They may, not to assume that they may have issues, but they may do. And not to assume that they're just there just to support. I mean, obviously they're going to support, but it's not kind of it's okay because they've got family around them. I think it's identifying that they potentially have needs and can be supported as well. I mean, an obvious one is the peer-to-peer support. There's research we've done, but others have done as well, around potential groups for families and spouses and caregivers of stroke survivors to gain emotional support by reaching out to others in similar situations. So yeah, I think it's more to consider their needs as well.
That's great. I'm going to say time is getting on, but this is really good. We've actually got a lot of questions. Some of the questions we've got so far really probably need to be answered in the next section because they're more about eligibility. So I'm going to ask one more. Is sleep disturbance an issue for stroke survivors? The answer looks like it's yes.
No, it's yes. It's really very common and often under-recognised. Obstructive sleep apnea is a risk factor for stroke when people pre-stroke have difficulty with their airways and oxygen levels overnight. So we know that there's pre-existing sleep disturbance, but you get a significant interruption of the sleep-wake cycle post-stroke that can go on for a significant period of time and really impact on what's already existing there in terms of fatigue. And I saw Lee nod, so it'd be good really to hear, Lee, what your experience was.
So that point about fatigue and planning your life so that you do get 8 hours or whatever it is, certainly not 6. And in my world it would be sometimes in different time zones it would be 5 hours, 6 hours, and it was definitely a case of over long periods of time I wouldn't get enough sleep, and then you do get enough sleep and you feel the difference. But absolutely post-stroke, for me, ensuring good quality sleep, uninterrupted sleep, getting to bed at a decent time and not being stressed to be up in the morning too early to then be somewhere makes a massive difference to recovery. And it also makes a massive difference to your efficiency when you are then entering your day having had interrupted or inadequate sleep. So one part of the ongoing recovery that I've got is to make sure I do get sufficient sleep, because I do feel I just have, I think as a result, less reserves that I would have just relied on and not thought about. And it just means you need to be more careful with, how late you're going out or what you're doing and what sort of the balance of your demands look like. And I think that certainly straight afterwards, dreams waking you up quite constantly was a factor for me. I would say, luckily I wasn't in UCL for too long, but the noise of a hospital is quite disruptive to victims in all sorts of cases, including at UCL and other places. When you're recovering from a stroke, you become acutely aware of noise, and it does, I think, disturb much more quickly, and probably may delay recovery for those important 48 hours or whatever it is after an event. So I think that for me was a factor. But as soon as you get home, you can then sort of take control of your own time, interruption, sleep, and I think for me it's remained a constant and a challenge.
That's great. Thank you. I think that's probably is time to wrap. It's as good a place as any to wrap up. Not that we're going to go to sleep because we've got some more sessions. So, but I'm just conscious that I'm not sure whether all of our clinicians are able to stay for the entire part of the webinar. But so I can release you if you need to go. So and we'll move on to the next session. Thank you very much indeed for all those answers, and just to remind the audience that we will be picking up questions and answers that we haven't been able to answer in FAQs, which we will publish on the website probably by the early part of next week. So I want to move on now and to introduce you to Piers Ricketts. Piers is the CEO of the Eastern AHSN, and he has until recently been in the overall network chair for the CEOs across the whole of network of AHSNs. And Piers is it's unusual for me to be chairing when Piers is speaking, because it's normally the other way around. And so, but Piers is going to talk to us about the AHSN network, what it is, and why why and how you should get connected. So Alice, we got some slides.
Thank you. Great.
Thank you, Piers.
Oh, thank you, Ian. Thank you, Alice. Good afternoon, everybody. I'll do the Chris Whitty next slide, please. Right, so yeah, good afternoon. I think we've got about 10 minutes just to give you a bit more of an overview of the AHSN network, so who we are, what we do, and how we operate. So as you can see from the map, 15 AHSNs. We are specialist organisations, largely, although not exclusively, funded by the NHS and the Office for Life Sciences. I've said here that we believe that we're the innovation arm of the NHS. There are lots of definitions of innovation, and people understand different things by that. But the definition I'd commend to you, and the one that I quite like, is in Matt Ridley's recent book, How Innovation Works. So innovation, he says, is the process by which an invention takes off because it is sufficiently well developed, well understood, practical, and affordable to be worth using at scale. So we operate after some of the early stage discoveries that you might have heard about earlier in today's webinar, and to say, how does that stuff get developed, either just before or just after its regulatory authorization, and how does it get into practice across our health and care system? And our contribution, I guess, originates from twin abilities. One is that we operate locally, so the 15 of us covering very distinct regions of England, so we're embedded in our local systems with relationships, trusted relationships, which enable us to work with our partners on different sorts of transformation. And the second one is that we are, as Ian has implied, a connected national network, and by operating as a coordinated network, we can horizon scan for existing and new solutions and then scale them up and get them to patients. So if we have the next slide, please. So roughly 50% of our work is national programs that we all do together, and the other 50% are things that each of us does in our regions. We've got about 700 boots on the ground, so each of us employs sort of 30 to 50, or in some cases more staff than that. So we've got a lot of people, and we've been doing this for 8 years now, so we know how a lot of this stuff works. And we believe that there's no other part of the system which has our degree of expertise in terms of how do you implement innovation, with the three objectives: improving lives, saving the NHS money, and that can be defined in different ways, and driving economic growth for the private sector, for our health and life sciences sector, and for academics who are spinning their innovations out into the real world. So next slide, please. So this is a couple of slides on our impacts. This one's I think it's the year 2019 up to March 2020. We've just released the corresponding figures for 20 to 21. They literally came out yesterday or the day before, so I've not had a chance to paste those into here. But you can see, working together and working nationally at scale, we think there are some quite significant achievements here. And if you look at the third one on the top row, given the previous conversation about stroke, we've had a big atrial fibrillation case finding and detection program, which we believe has helped to prevent nearly 12,000 strokes and save nearly 3,000 lives. And that's on the basis that This work has been led by my colleague, Professor Gary Ford in Oxford. For every 1,000 people whom you anticoagulate properly, you save, I think it's 12 fatal strokes and an additional 15 life-changing or debilitating strokes. So if you do the numbers, the number of people that we've managed to get to between the 15 of us over a 2 or 3 year program, that's the kind of statistics that you get to. There's some other, particular programs that we've done. An emergency laparotomy safety pathway. So now that sort of care bundle we think is in almost 100% of acute trust, that one in the middle of the top row. And the industry one, actually we might come on to on the next slide. So if we could have the next slide, please. Thank you. So yes, this is the other side of our work, as well as putting innovation into our health and care system. Obviously, we do valuable work in working with industry and helping industry, whether it's the tiniest and earliest stage startup, or sometimes it's big tech and big pharma, positioning their wares in such a way that the NHS finds it easier to take up. So we do an annual survey, and in this year here, we believe that we helped entrepreneurs and innovators and companies to create 580 jobs and safeguard a further 480, and we helped to leverage over £300 million of external investment into the UK's health and life sciences sector. And for the year just ended, March 21, that figure I think is close to 600 million, which I think is interesting, particularly because of course we've had a year of the pandemic, so we've been able to continue doing this stuff and to do it bigger and broader. Next slide, please. So you've got a couple of case studies. This is the atrial fibrillation one I mentioned just now. The idea being, to improve the diagnosis of people at high risk of AF who hadn't previously been picked up. And we've done this with the portable ECG devices in a number of different settings. We're based in the east of England, and some of my colleagues spent a weekend at the Suffolk Beer Festival, going around with a sort of quite fun portable devices, again, picking up people in a sort of unusual setting. And then obviously, if there's a potential chance that you do have AF, you have a proper 12-lead ECG in the right setting, and then you get onto the right medication. And you can see some of the statistics there, which, this is probably the most far-reaching program that we've done, and we're quite proud of this. So it's a sort of technology-enabled transformation, working initially in a couple of regions in England, and then spreading it out across the country. Next slide, please. So this one is one of the rapid uptake products. So every year there's a number of medicines which have their safety approval and their nice quality and economic assessment, but for some reason haven't really got into the mainstream. So there's 4 or 5 that the Accelerated Access Collaborative selects according to certain criteria each year. And this is percentile incremental growth factor, which you'll know is a test that helps to predict or rule out the risk of preeclampsia pretty quickly, as opposed to the often sort of more trial and error and lengthy process that typically would have been gone through. And you can see that when we started working together on this in June 2019, it was offered in a very few maternity units. By the time we finished this, December 2020, we got it into, I think that's nearly 90 maternity units. And you can see on the right-hand axis the number of tests that we give them. So the NHS pays for the medication over a 2-year period, so it's freely available to trusts and commissioners. We provide the implementation, clinically led implementation support across every maternity unit. And there's a number of these different things that we work together on. Next slide, please. Thank you. So we pivoted quite rapidly March last year at the start of the pandemic. Most of our national programs did actually continue, but albeit slightly more slowly. But we worked, we wanted to work on some of the big things that the NHS was facing. And the first and obvious one was the move to the uptake of video and online GP consultations. So the NHS had procured a number of systems of software. There was procurement available, the money was available, the framework was available, and we worked in blended teams with the NHS regional teams, with NHSX, In the east of England, we got free input from AstraZeneca's team. So obviously, you know, the pharma field force were grounded and couldn't go out. So they worked with us, you know, for free for 3 months to help implement these. So every, you know, GP surgery was able to take advantage to a greater or lesser extent of video and online consultations. We've done a lot of work on electronic repeat dispensing to make that broadly available. And then the one that was perhaps most sort of specific was the COVID oximetry at home. So the virtual ward pathway that, you know, by the use of home oximeters, which NHSX bought tens of thousands of, these were distributed through primary care, and therefore people at risk of COVID could, you know, avoid admission until the last possible moment by regulating their oxygen with the use of home oximeters in collaboration with primary care, and similarly can be discharged perhaps earlier, given that that monitoring and that clinical pathway with GPs was in place. So we helped roll that out to every region in the country, and there's a couple of other things there as well. And of our 700 staff, probably about 150, 160 worked full time in various parts of the NHS on, you know, some operational stuff during that time. So that gives you an example of some of the things that we do at scale. And what I thought we'd sort of finish with was just a little bit more detail. I think Guy's going to talk about a stroke innovation in a minute, but we've got 3 sort of slightly more detailed case studies, some of which we've mentioned on this page. But if we just flick through these, so the next slide, please. So this is some of the alternatives to face-to-face consultations, whether it's primary care, online, or in video. I think the online triage there from 45% through to 85%. This is some of the pretty unglamorous plumbing and wiring in terms of digital. And in the east of England, you know, there are 3,000 laptops, I remember, that turned up at the dock on it in Ipswich on Easter Sunday, I think it was. So, you know, because not all GP surgeries had compatible or proper encrypted or secure laptops. So some of the basic plumbing and wiring we did, but also in terms of the how-to guides and the more nuanced ways of using some of this technology. And then you can see in the bottom half of the slide there, some particular work in London about the implementation of Attend Anywhere, which is a secure web-based solution for secondary care, generally secondary care outpatient appointments. And again, it was free to use. There was a procurement framework, but that doesn't necessarily mean, of course, that secondary care practitioners are automatically in a state to, you know, to install it and use it. So there's a lot of implementation of the tech combined with clinical advice. Next slide, please. So this is the COVID oximetry at home and the use of virtual wards. So you can see there in the middle, over 12,000 patients have benefited from the COVID at home service. And we're now exploring the use of virtual wards for lots of, you know, different types of pathway. Clearly, there are parts of the country that are well on with this, whether it's in respiratory or cardiac medicine or lots of different types. But, you know, there's a model here which we can expand, adapt, and roll out more fully. And the final one is quite a nice example, if we could have the next slide. Supporting the development of PPE, so you'll recall the awful crisis back in March and April, you know, when there wasn't enough. And this is our colleagues in Wessex Hsn, so based in Southampton. The University of Southampton had developed a personal respirator, which you see illustrated there. There was no prototype, no manufacturer, no view on actually how it would work and where it fitted within the guidelines. And they worked really quickly with the university team to get the relevant approvals, to manufacture it, to get the CE mark, and actually, you know, get it into practice. So that was a really nice sort of little example of how you accelerate an innovation and get it into practice. Although that one hasn't gone that wide yet. And a final slide from me, so we can have the last one. Our contribution to government policy. So we think there are lots of lessons to be learned from all the implementation work that we do. And if you think back to, for example, a placental incremental growth factor, a medicine that was known, you know, that was known to many in the community, but for some reason wasn't widely adopted. And it's not enough for ministers and policymakers to say, well, we think this is really good, we're going to choose this. Here's some free medication, you know, here's some slides about how to implement it, off you go. And I think we've managed to raise on the agenda, raise the importance of how you do implementation. And we've recently, a couple of weeks ago, so it's not on this slide, published our own view of how you adopt and spread innovation, which is on the Hsn Network website. We also recently issued the one bottom left there, which is our health and care reset campaign. So how we look at some of the priorities facing the NHS as we start to move out of the pandemic, with the issue of the elective recovery, the focus on inequalities, and the need to be much more alive to equality and diversity. And my colleague Richard Stubbs in Yorkshire and Humber Hsn has done a lot of interesting work on that. So, you know, we've got boots on the ground. A lot of the stuff we do is very practical, but we do also have an influence, an increasing influence at the policy level as well. So that's a pretty quick tour, Ian, of you know, who we are and how we operate. But I hope that's given the audience, you know, a bit more of a sort of firm idea about who we are and what we do.
That's great. Thank you.
Impact report came out yesterday. So there you go.
Yeah, thank you very much indeed, Piers. That's really helpful, and that's explains some of that's one of the reasons why we are encouraging applicants to be in touch with their local HSNs to be part of this. So let's, without further ado, let's move on to Guy Rooney, who's the medical director of Oxford HSN. We've already heard a couple of times from Guy already today and answered some questions. So Guy, would you like to take it away, please?
Hi, would you like to start the slideshow? Okay, next slide, please. So what I wanted to talk about today was the work we've done at Oxford HSN, working with a company in the stroke field. I thought that was sort of relevant to the talk. I think the clinical input that we had highlighted the complexity and the multidisciplinary teams needed for that sort of early diagnosis. And we know this in the long-term plan that we want 90% of stroke patients receiving the specialist their care in a specialist stroke unit, the increased number of patients receiving thrombolysis, and the increasing number of patients who actually receive mechanical thrombectomy. To try and achieve this, we set up the Titan Group in the Thames Valley about 2 years ago now, where we brought together 6 acute hospitals. One was a hub, 5 spokes, to actually work on that pathway. What became increasingly important is we actually brought in an innovator, Brainomics, right to the beginning. Well, I think they approached us, and this was an innovation that had come early out of the sort of Oxford clinicians, and they set up a company called Brainomics, which was going to help in the sort of the early diagnostic part of that stroke pathway. Next slide, please. So whether you're when you're sort of, if you present, in the case of, I think, Ian, into the Whittington Hospital, if he'd come on a sort of traditional stroke pathway, you would have had lots of scans, and speed and timeliness is very important. What happens with the Brainomics part, it's an AI technology which gets all these images, which are quite complex, and sort of, I'm going to speak very simply because I'm not a technician, puts it through the AI, and within minutes develops a complex sort of pictured map, which gives you an indication of whether it's a type of stroke that will be amenable to mechanical thrombectomy. Now, traditionally, this would require someone with expertise, have to ring up someone, they get to interpret it. This actually gives you a guide and a tool to actually to be more certain that you're making that diagnosis and to speak to the right people straight away. The other important thing about this AI technology, it also allows you to communicate that information and communicate those images instantly via mobile phone or via the internet to another clinician, particularly at the hub centre. It takes a while, but we worked on this within the Titan, and we were the first network in the UK to adopt this AI across the network. And what we've done as part of the Titan Group, we're really looking at the whole pathway, we're mapping the whole pathway and measuring it, because we really want to speed up that point to where decisions are made and where a patient is getting their treatment quickly. As part of sort of where we've come now, we've actually beginning to see a real impact on decreasing that door in, door out time. And we've set ourselves a local ambition to actually keep the ambulance there. Now, what does that mean? Well, a patient maybe collapses at home, is brought in by ambulance. The ambulance has to leave to go and treat other people who may need to come to hospital, etc. But we've had discussion, if we could actually really make that pathway so much shorter that we could get that decision and those scans and that interpretation done in 30 minutes, would the ambulance stay? If the ambulance stay, then they can go straight back in the ambulance and go off to the hub centre to have the mechanical thrombectomy. Part of this work, working with Brainomics, is that we've been developing with the company. They've been able to roll this out with other areas, and they're also rolling out internationally. And they were lucky enough, and rightly so, were awarded an HSX AI Healthcare Award in the first round. And for any of you interested, there's a second round has just been announced. There's a third round coming. The winners have just been announced, and there's a third round coming up. So that's another area you may think of in terms of developing your AI technology. Next slide, please. So as part of that award, they've now got a number of networks, and these are on the map. When we've escaped England, we've made it to Scotland, which is very good. And it's involving actually 30 to 40 hospitals. And this award just actually begins to fund. I mean, you begin to see the growth of an idea amongst clinicians who are both in Oxford hospitals and Oxford University. They begin to develop something, they form a company, they connect with the AHSN. The AHSN, we help facilitate their connection with local network. That begins to get adoption, gets approval. And then it gets into a state where it can apply for a national award. And if we go to the next slide. And the beauty of this national award is that we're really able to just gather evidence in the real world. So there's lots of what we call research evidence, and that's more under much stricter control. But we know that when you try and translate research evidence into real world, all sorts of things happen, because actually there are people out there, there are systems out there, there are patients out there, there are all sorts of things happening that can influence how something actually happens in the real world. So now, as part of this award, the AHSNs are also helping to look at the deliverability, the integration, and to collect these sort of quantitative data on how things speed up. But importantly, they're also doing a qualitative piece of work, actually asking people both involved in the pathway, both clinicians and patients, what it was like for them and how important this piece of initiative is. Thank you. Next slide, I think it's the end. That's all. That's my brief tour about how the HSN has been involved in the beginning to the end of this development. Thank you.
That's great. Thank you, Guy. So if Piers and Guy, oh no, hang on, we've got the next presentation first. Sorry, before we get to the Q&A, I'm leaping ahead already. I think we're now going to hear from Randa a little bit about the practical aspects of how to actually apply and what you need to do if you decide to apply for the competition. So,
thanks, Ian. Yes, as I mentioned earlier, there is an application and assessment process that's involved. So I'll just give a brief overview of what that looks like. So the process begins by us inviting innovative companies and organizations to come forward with creative solutions to the challenges that we've spoke about today by submitting applications. And these applications are reviewed by a pool of experts covering clinical, technical, and commercial expertise. And those applications are then shortlisted. Following shortlisting, the shortlisted applicants are invited to submit a video pitch to support their application, and that will be reviewed and discussed by a panel of experts during the panel meeting, who then decide which applications will receive phase 1 funding. The outcome from the panel meeting will be communicated to the applicants after the meeting, and contracts for successful applicants will be awarded shortly thereafter. If the awardees are successful at phase 1, they can bid for phase 2 funding to continue the development and testing of their product. Phase 2 funding is not guaranteed, and it is a competitive process as well. So the phase 1 awardees will be invited to submit a phase 2 application towards the end of their phase 1 project. And this is assessed by external peer reviewers and once again reviewed by a panel of experts. The applicants will also be invited to present to the panel, who again will decide on which application will receive phase 2 funding. And once again, the outcome will be communicated after the panel meeting and contracts awarded shortly thereafter. Next slide, please. Oh, can you go next, please? Yeah, sorry, it didn't show through. Yeah, thank you. Can you go to the next slide, please? Sorry. Yeah, so with the application process, we do have a lot of supporting documentation to help you navigate the process. And these include the invitation to tender document, the applicant and portal guidance, a challenge brief, which outlines the scope of the competition, a template application form as well, and frequently asked questions that you could also look at. And all of those documentations can be found on our website under the Stroke and Technology competition webpage. And just a reminder of the key dates, we're looking to launch on the 13th of July. The deadline will be the 24th of August, and the assessment in September, the panel in October, and contract awarded by November time. Next slide, please. So when it comes to making submitting an application, this is done through the RMS online application portal, and only registered users of the portal can apply. So if you are new to the portal, you'd need to register as a new user. Otherwise, if you are an existing user, you would just log in. Next slide, please. Once you're logged into your account, the homepage is where you will be able to create applications, access co-applications, and update any contact information and details. It's important to note that the contact information that's entered during the registration process will be automatically transferred into the relevant fields during the application process. So if you do need to make any changes to those details, you can manage that through the Manage My Details link on the left-hand side there. And to start a new application, you will either find a link to do so on the homepage under the new grant application, or you can go to My Applications in the left-hand menu and click on New Application button once you're there. Next slide, please. Once you do that, you'll be taken to a page with a list of open funding rounds that have further information about the competition. So you'll just need to make sure that you find the correct competition call and category, and then select Apply to open up an application form. Next slide, please. From there, you'll be directed to the application summary page, and the different sections of the applications can be accessed via the list of the hyperlinked buttons on the left-hand side. Most of the questions throughout the application form have help buttons that provide brief guidance notes. But as mentioned, there is an application and portal guidance document available on our website. So please do refer to this document if you need any further information on how to complete these sections. You will be prompted to save your work if you do leave your browser whilst you're in editing mode. So we recommend that you save your work regularly to minimize the risk of losing your work, and you can save and return to the application form as often as you like prior to submission. Next slide, please. If there are team members or project partners involved in the project, the lead applicants will need to invite them as co-applicants through the team section of the application form. And once invited, the project partners will receive an email to confirm their participation in the application, and they'll be invited to log into the application portal and confirm their participation by going through the My Co-Applications link. Next slide, please. Once they've selected the appropriate application, they'll be redirected to this summary page where they can follow the links to confirm their involvement. And once confirmed, they'll be able to have access to edit the online application form. It's important to note that all project partners must not only confirm, but also approve their invitation to participate, which they can also find in the summary page here. And this needs to be done in advance of the submission deadline. Otherwise, you're not going to be able to submit your application form. So please do bear this in mind and keep in mind that there will be that time to get that sorted out before submission. Next slide, please. When the application form is complete, it needs to be validated prior to submission. And the validation step is just a check run to make sure that all the mandatory fields have been filled out. And once the application has been validated successfully, the lead applicant can then submit the application by clicking on the Submit button. Next slide, please. As mentioned previously, I know it's a lot of information to take in. There is the guidance document available on our website, which has all the steps to go through when going. But moving on, I've mentioned previously that phase 1 applications are going to be reviewed by a panel of experts, and they're going to be assessing the application based on the following criteria. They're going to be looking at, the proposal and how well it addresses the challenges that were outlined in the brief. They'll look at the project plan and how appropriate the deliverables and strategies are around risks and mitigating those risks. They'll also be looking at the competitive advantage of the solution over existing solutions, how innovative the technology is, and what arrangements you have in place in terms of the development of IP, commercialization plans, as well as rollout and implementation plans as well. They'll also be looking at the level of patient and public involvement, as well as the potential of the technology to enhance equity of access and contribute to net zero emission. So the SBRI healthcare program is committed to supporting the NHS in reaching its targets to enhance equality and diversity, as well as reach net zero by 2040. So those will be looked into. And finally, they'll also be looking at the project team, whether they have the right experience to deliver the project, as well as the costs to see if those were appropriate and if there's value for money. Next slide, please. And then finally, just to give you an idea of the success rate, so far across all the competitions run to date, we've had around 2,400 applications scrutinized. And of those, around 9% have been funded at phase 1. And of those that were funded at phase 1, around 50% have gone through to phase 2. So it is quite a competitive process, and it's just something to bear in mind. But that was all in terms of the overview of the application process and what's involved. We will be having a Q&A session. So again, if you have any questions, please feel free to ask them then.
Great, thank you very much, Randa. Could I ask Piers and Guy and Fanny also to come back on screen, and we're probably going to overrun by a few minutes while there's plenty of people still here. I've got some questions, and particularly wanted to pick up on some things around AHSN. So I've got a question here from Alison, who says, are there any way for health tech companies in Northern Ireland to connect in with AHSNs, and if so, what particular AHSN should be connected with? And I think I'm sure it's got 3 pluses on there. So I'm assuming there's either 3 people from Northern Ireland, or there's people from outside, at least, of England who are interested in this, who are obviously eligible to apply. How do they connect into the HSN network, and what's the best way of doing that? Piers, that might be for you.
I'm assuming that's for me. So there isn't a sort of replica of the AHSN structure in any of the devolved nations. The commercial director at Yorkshire and Humber AHSN, who's a guy called Neville Young, and you can look him up on their website, has, I know, done some work in Northern Ireland, so he'd be the one to go to for that. Wales, the government has appointed a sort of director of health innovation, who's somebody called Jonathan Gray, based at Cardiff University, I think. And in Scotland, there will be schemes because obviously you've got some fantastic universities and research capability there. But I'm afraid I don't know the answer to that. So Neville Young, I think, for Scotland and Northern Ireland. And then if you can look to Jonathan Gray, that's Gray at Cardiff University for Wales.
That's great. Thank you very much, Piers. I guess similar question. That's about dedicated AHSN contacts. So if you look AHSN network, put AHSN network into Google, it gets you to the page. You can go and look at your shows you the geography. Yes, you can look at your local network, and pretty much all of them have got named and contacts details on the website, so they're very easy to get hold of. If you particularly wanted to, or if you've got other questions that you want to come to the PMO with anyway, we can also ask you those questions and connect. We'll probably ask you if you're connected to the HSN anyway, and if you're not, we'll tell you where to go. So Guy.
I don't think it's a requirement that you have to connect with the HSN to apply for this grant. Sorry.
It isn't a requirement.
I just want to emphasize that.
Strongly encouraged. It's strongly encouraged. So So I also want to say there's quite a number of questions. I'm conscious that we are running fairly short of time, but there are quite a number of questions about signposting and making connections between different sorts of organizations. So we've got organizations that are companies that are looking for clinical or academic collaborations, and I think we've already had that sort of partially answered that question in the last session, which Guy popped up to say, and I think the AHSNs would be a key partner in making some of those connections for you. So if you're also, it's worth saying, and I think my colleague Catherine is going to post something on the chat in just a moment, a link to the NIHR's signposting service. So if you need access to clinical researchers or parts of the NIHR infrastructure, in particular, I'm thinking of the MedTech in vitro diagnostic cooperative group, then the NOCRI team, through their signposting service, which is just popped up in the chat, can connect you with them and can navigate that for you. So if it's the other way around and you're a clinician or you're an academic and you've got an idea and you're looking for a company, that's sometimes a little bit more difficult, but we can, I think, again, the AHSNs can help you in that aspect. And if you yeah, there are a number of organizations, and I guess again the PMO can also help to signpost you in some of those directions. But if you've got those connections to the HSNs or come to us, we can point you in a direction of someone who can help you. PMO are not in a position to be able to say, yes, go and talk to that company, they're really good. We're not allowed to do that. But what we can do is we can go and say, maybe talk to Medilinks or talk to that particular accelerator or that cluster of companies in your area. They know how they have these people on their books, they can help you and signpost you. So I think that will answer quite a number of the questions that we've had here, because again, so there's clearly an issue around signposting and some matchmaking, and it might be something for us to think about. Fanny, you want to say something?
Yeah, Ian, I just also wanted to mention that the call is in partnership with Stroke Association, so they also have a lot of contacts, and it's worthwhile considering if there's any links to be done to that we can signpost to the Stroke Association for help, but also signposting towards patients and public for that type of engagement.
Someone's just asked me to mention the mix. I'm sure that's someone from a MIC. I've just done that, so that's good. Is there a limit to the proportion of funding available to universities who are part of a collaboration with an SMA who is a lead applicant? That's probably one for you, Fanny.
No, so is the question about the funding that goes to university if they are partnering with an SME? There's no limits. I think all comes down to the justification of cost and how the university is involved with the project. So no, it's just, whatever work needs to be done with that particular university is justified, and we can fund it.
Okay. Gonzalo would like to know whether the innovation needs to be CE marked and ready for commercialization after phase 2.
No, it doesn't, and it really depends on the type of technology or solution. Some can get CE mark evidence very quickly, some others aren't. And some projects will obtain CE mark towards the end of their phase 2, but I would say that's quite rare, and that's not an expectation of the program. So it's just taking the right steps to be able to demonstrate the evidence ultimately.
That's great. I think actually looks like there's been a lot of typing going on in the background, because lots of the questions that were asked have now seemed to have been answered. So I think at that stage we probably want to call it a wrap for today. And I want to just say a massive thank you to all our speakers, particularly Deb, who looks like she's hung on till right at the very end, and to our other clinicians, and particularly to Lee, and also to Piers and Guy for coming and speaking about the HSNs. On the screen you'll see contact. So it's worth, please, if you've got questions, further questions, first of all, if you've asked a question today, all of those questions will appear on the FAQ on the website, and you'll get, if you've been a part of this webinar, you'll get sent the links directly, but they will appear on the website. This is the contact details for the PMO, so we can you can make contact with us and talk to people. There's a dedicated email address which will be managed, and if you've got questions about your eligibility. And the other thing I need to say is on the 12th of July, which is just conveniently come up on a slide for you, on the 12th of July, we're going to do a drop-in session for Q&A. So there'll be an the whole session for the hour and a half will be available for doing question and answers, but there'll be an opportunity for you to have a one-to-one session with someone from the PMO if you want to talk about something very specific about your particular technology or your idea, concept and application and what you want to do. So that will be available to you on the 12th of July. And again, when you get the email following with the links in, you'll get an invitation to that meeting with the details for that. And I think with that, that's probably all I need to say. I don't think there's anything else I need to say at this point. So just thank you very much indeed for attending, and good luck with your applications.